Hello, internets. This is Mark Gramling, VP of Oncology at LARVOL. We've been off for a couple weeks here. We're trying to get back on schedule, kicking into the new year. This week on Oncodata Podcast, sometimes we talk about deep dives of conference disclosures. Sometimes we talk about and cruise around the CLIN platform or software platform. But sometimes we dive into more particular subjects, and it's very nice to have Dr. Abdallah joining me today from University of Kansas Medical Center and the U.S. Myeloma Research Collaborative. And so today we're going to be sort of doing a different type of dive about, usually we talk outcomes data, but today we're going to be talking a little bit more about myeloma and also access to treatment. So super excited to have Dr. Abdallah joining me today. So if you would be so kind to give a more proper introduction of yourself, your group, and your research focuses, and then we'll do our rapid fire podcast from there. So thank you, Dr. Abdallah, for joining me.
Thank you very much, Dr. Gamble. And I think, I really appreciate hosting me here today. My name is Dr. Al-Ola Abdallah. I'm one of the myeloma physician here at University of Kansas. Been here for about 10 years. I'm the director of the plasma cell disorder and also the chair of the U.S. Merck U.S. Myeloma Innovations Research Collaborative Group. Of course, this is a really big honor to kind of like also participate and to talk about one of the issues that we talked about that multiple times. I mean, we have a lot of great advancement in treatment of multiple myeloma, but also there is a question have been asked multiple times during our journey from approval to treatment. Is this access, is there any kind of restrictions for access to these treatments, whether it's in the United States or worldwide? And I think that was a very important subject because we talk about the outcomes and the results and about changing the guidelines, but nobody actually talk about what about the access for these treatments.
Fair enough. Well, I think that sets us right in to really be targeted on that. I know you're a driver of, I hope I'm not mispronouncing or underpronouncing the GLAMM study,
Yes.
talking about access to multiple myeloma. And I saw that this was presented as an abstract at ASH. So ASH was, wow, it's February already. So I guess a couple months back. And I think maybe you're also moving that into publication. If
Yes.
just to go right into the topic, since we're short on time, sort of what was the overview and the objectives of that GLAM study about access to multiple myeloma treatment?
Absolutely. I mean, so here's the catch that we really actually kind of ask ourselves is that is are the treatments that we have available here in the United States also available worldwide? And if it's so, how easily they're accessed, or if there's any kind of disparity? And we were shocked and surprised that there are many countries, even those who have high income countries, that have lack of access, especially the cellular
Hmm.
therapy that we have actually really great opportunities to see the results of that. And that kind of like trigger that biggest point about like, can we actually, first of all, quantify if there is a possibility about what kind of drugs and what kind of countries that have lack of access for these treatments. So we targeted many oncologists worldwide, both sides, those who have high healthcare investing nations, and these countries usually provide more than 10% of their GDP for the healthcare versus low healthcare investing nations that provide less than 10% of their GDP for their healthcare. And we start seeing like there is some differences, but the cellular therapy was lacking in both sides. So that actually show us there is a lot of red flags that we really need to raise it up. Is there any kind of like disparity in access for myeloma treatment, especially the newer therapies to these countries? And we want to study it not only what kind of difficulties they have, what are the main restrictions, and if these restrictions can be overcome in the future. And I think that was our biggest goal: is first of all identify the problem, identify how advanced it is, and how much it is spread over the worldwide.
Sure. Well, I guess it's almost a naive question, but is there something unique to myeloma relative to other hematologic malignancies or other cellular-based therapies that made myeloma particularly interesting to study? I know it's
Well,
a very broad question,
I,
but
that's a
it's a
great
great place
question.
to start.
Absolutely. No, I agree with that. I think we want to start it with the myeloma for a couple of reasons. First of all, because our institution kind of like have been focused on multiple myeloma, but we also have other group who actually focus lymphoma leukemia. Number two, also, Mark, we have our belief that myeloma treatments with every class of therapy had improved the survival. If we want to do one for lymphoma, I know there is the CAR T cell recently improving survival, but also don't forget the majority of lymphoma patients get cured disease. So I think we want to actually look at
Hmm,
myeloma from perspective. There is a big survival benefit, and lack of access to treatment in multiple myeloma is going to cause decreased survival comparing to our myeloma patients here in the United States. So I think we want to also kind of like say, okay, yeah, we have seen improvement survival from years and years for 20 years. Like patients used to live for 6 months to 2 years. Now we're looking at 15 years. There's a big difference. It didn't happen for no reason. It really happened because we have really great tools of treatment, and these tools are available here in the United States, and that's where I think it makes a big difference to actually study if these countries have that. Some countries are well known; they're high economically, and they don't have access to bispecific or CAR T cell. And I think that kind of raised the red flags for us, like that will that impact the survival worldwide or not?
sure. Well, I guess to go, um, and that makes sense, especially in lymphoma being closer towards curative versus multiple myeloma. So you can definitely see that. I hope I'm not. It's obviously you're an author on the study, and I would never want to remember live on a podcast. But I think the highest limitations from my recollection in terms of least access to therapies, I think were North America and Africa. And for the uninitiated, I think that would be quite surprising. But maybe I'm just seeing that. I guess I'm sort of setting up the question of, what are the contributing factors to those disparities? I think we all understand the differences in healthcare systems, especially the US versus maybe Europe. I think we're all
Correct.
aware of obviously economic disparities, but that jumped out from the publication at ASH. So,
Correct. So we have to understand a few things. First of all, we started this as a survey, and I think
mhm,
one of the negativity and one of the major limitations of survey is that we're going to be a little bit biased in terms of like trying to have really great connections with some of the colleagues, who have access to drugs or not access to drugs. That's one of the things. So the other limitation, geographic limitations, and not, we send to many countries, but there are a lot of countries who we did not receive some answers for that, and unfortunately that kind of like also leave a gap. Some of the countries is in Africa, so I'll tell you it can be even lower than this. Some countries answer these questions. So I think the limitation for the survey is really acknowledged, but as we talked about in the past, we really need to start somewhere, and that was one of our biggest goals. Start somewhere, see exactly where are the major gaps and limitations, and then we want to try to kind of try to figure out and dig a little bit deep and see what are the causes of these access, inability to access to these drugs. What are the major causes? And I think the number one cause have been always financial. And I'm not surprised, Mark. I mean, the financial
mhm,
problem, especially now with the CAR T cell, it's really impressive. Like you talk about CAR T cell, $500,000 a cost of the CAR T cell. That's something,
yeah,
it's really expensive. You're talking about countries that I don't think they can afford that. And you have to understand there's some countries they have different type of insurance. The government kind of provide these insurance, and I think when they look at it, that's a big burden on them. So financial was the commonest cause of restriction for many of the treatments, whether these are drugs, some type of CD38 monoclonal antibodies like daratumumab or isatuximab, or even pills like Revlimid and pomalidomide. These are very expensive drugs for these countries that they can't afford using it. Or some of the countries they were saying it is accessible, but for limited time. Some like Revlimid, they'll tell that we will give it for 6 months or up to 1 year. So they have access to it, but they will not give it like um, to be used freely as the physician can prescribe, it's more likely they will give you some limitations of time.
Hmm. When I hate to ask such a I don't know if you call it a self-interested question, but within the context of access within North America, was this parsed between Canada, US, or other parts of North America? Because
So
obviously there's
us,
very
yeah,
disparate healthcare systems between the US and Canada. So I guess
correct. Yeah,
as an American asking that question.
US was excluded. So when we meant
Okay.
North America, we exclude of course we made global except the US
Okay.
in that case, because US have all the drugs in access. And I think if we want to make that convergent, we're going to have to do a different study just for all centers in the US. So US was excluded completely.
Mhm. Well, are there, I guess maybe that, you said it merits another study, but are there, while there's the availability of cellular therapies in the US, it's not my specialty, but I presume there's reimbursement challenges within the US as well. I don't know the differences between different cellular therapies or bispecifics, but I would presume that there's barriers to that based on the US insurance system.
Yeah, I agree that, Mark, and I think one thing in addition to the cost of the financial, worldwide, is that also we don't forget, like, also we have this challenge at the beginning, but maybe that we're overcoming it, is the logistics, the infrastructure for giving the CAR
Hmm.
T cell and the bispecific. I think that's also another major issue. Many of the uh, global countries, they don't have that access, and I think part of it, Mark, is that and we maybe that's something have to be studied, is that they don't have clinical trials, and that's very difficult. Like, the trials, having a clinical trial may make it easier for developing these infrastructure in these countries and make it more available in the future, and maybe if they overcome the financial burden in that case. I
Hmm.
think that played a big role as well. We know that by fact because, for example, KU Center had opened many clinical trials for CAR T cell and bispecific. We didn't have any problem when this got FDA approved. But if you look at other hospitals, bigger hospitals, if they didn't open these clinical trials, they have a lot of struggling to open these, or to start the treatment after the FDA approved it. So we know by fact that, clinical trials, in our opinion, played a big role to actually kind of make it easier for us to open these or get these drugs available. And I think the same thing applied to globally. The countries is well known they don't open clinical trials. And I don't know if we actually can match this study. We can try it in the future to prove that clinical trials helped a lot to get these drugs access in
Hmm.
their countries.
I think that's an interesting layering because I guess I typically think of logistics as you phrased it, differentiating, say, major medical centers versus, say, community oncologists. But it seems to be what you're saying is in the context of cellular therapy, even major medical centers have to have the logistics, and that those are driven by trials, and then that feeds forward.
Correct.
So that's sort of interesting that you don't think about in maybe other types of interventions don't require that type of logistical. So it's 2 to 3 layers on top of already so many layers of the logistical limitations. So I typically don't think of it that way. I guess I need to spend more time on my on my cell therapy knowledge. So
Yeah,
fair enough.
and Mark, also you mentioned one major thing, and I think this is also a high burden financially, and also it's also burden on the hospitals. Like, well, for now, I think in the future this might be overcome. Is the hospitalization for the CAR T and the bispecific? That's a big financial burden, and also you need a full team, for the nurses, the nurse practitioners, the ICU team, neurologists. The big question here, Mark, is that also available in hospitals globally? I think also they have limitations. I mean, they might not have. Some centers have floors just for cellular therapy. Floors for cellular, yeah,
Yeah.
they have a dedicated floor for that, and they have these algorithm built in. I think that's a very challenging case that it will take years for them to develop that.
Fair enough. Well, I think we have just scratched the surface. I say it every podcast. It was maybe a poor decision to make this a 15-minute podcast because it's just scratching the surface, but I would definitely encourage anybody listening to check out the GLAMM study. Give it a Google. You can find the ASH abstract, and soon, I guess, probably seeing in a peer-reviewed journal, TBD. Is that a fair statement?
Yes. We don't have yet a date, but yes, this will be published.
Awesome. So look out for that. And also, if you're on our Clin Oncology platform, throw Dr. Abdallah's name into the search button under influencers. You'll see he's one of our digital opinion leaders from Clin. I guess that's how this conversation got initiated. And thank you, Dr. Abdallah, for joining me today.
No problem. Thank you very much, Mark, for actually inviting me today in the OncoData podcast.
Thank you, sir. Thanks, everybody, for listening. Have a good day.